Sorry, I had some technical difficulties.
Of course, we understand and we appreciate so much that you are here today with us. I would like to make a brief introduction. Okay, so now officially we are starting our class. Good morning and welcome to H.E.L.P's virtual classroom. I am Carrie Traub, a community services assistant here at H.E.L.P. We are very fortunate to have a special guest today, Dr. Hani Salehi-Had, a prestigious local ophthalmologist specializing in the area of macular degeneration. Dr. Salehi-Had had completed his ophthalmology residency at Harvard Medical School, Massachusetts Eye and Ear Infirmary. He is a member of the American Academy of Ophthalmology, American Society of Retina Specialists, and the Association for Research in Vision and Ophthalmology. Dr. Salehi-Had has authored several peer-reviewed publications and has presented at multiple international research conferences. He is currently participating in several clinical trials, offering the latest advances in medicine to his patients and helping to shape the future of vitreoretinal disease and surgery. Welcome, Dr. Salehi-Had.
Thank you, Carrie, for the kind remarks. Thank you, everyone, for joining. Bear with me if there is any technical difficulties. I'm not the best Zoomer here, but we'll definitely try to get the information across.
I am going to allow you now to share your screen. Is that okay,
Great.
Doctor?
Yes,
okay.
Of course.
Okay.
Let me see. Do I have to press on share screen?
Okay, so give me just a second. Yes, press on share screen. You should be allowed to do so. If you find any difficulty,
yeah, it's not letting me because it's
not letting you. Okay. Okay. So perfect. Okay. So just give me a second. Okay.
And by the way, the voice is okay for you guys. I want to make sure everyone is hearing correctly.
Yes.
Okay, great.
Okay, Doctor, can you share now your screen? Can you check it?
It looks like we're going to be able to do that. Share. So let's see if we can start this now at the very beginning. Okay, we're on. Okay, thank you again for joining us this morning. Again, I'm Hani Salehi-Had. I'm a retina specialist that work in Southern California. Few office locations. The main ones are in Torrance and Huntington Beach. I wanted to kind of go over what macular degeneration is. I'll do a quick overview of the talk and then discuss the different things that we have to offer patients with macular degeneration. So macular degeneration is the leading cause of vision loss in Americans that are 60 years or older. It's the second most common cause of irreversible blindness in the world, actually. So it's very prevalent and very common and very devastating when not treated. As many as 11 million people in the United States have macular degeneration. These statistics are a few years old, so this is much higher now. And this is equal to all types of cancer in total. Only 52% of adults know exactly what macular degeneration is. So awareness is an important issue that we still need to tackle and get across. As you may know, most people value their vision significantly compared to all types injuries. Visual problems are ranked one of the highest in terms of significant impact to people's lives. In 2004, the annual direct medical cost of macular degeneration was about $500 million, and this in 2010 was $2 billion, and this is expected to continue to increase. Briefly, in this talk, we'll go over signs and symptoms of macular degeneration, risk factors, different classifications of macular degeneration, what the treatment options are, and what are the new clinical trials and emerging therapies offering this. As the US population is aging, we can see that as baby boomers get older, large segment of the U.S. population is going to fall under 65 and older. In terms of numbers, we're about somewhere between 50 and 55 million people. Prevalence of macular degeneration with age, we can see macular degeneration is significantly correlated with age. So this is, generally speaking, a condition that occurs in patients older than 65, but the prevalence really jumps up after 75 and 80 years of age. Again, this is a age and gender specific prevalence pattern. You can see across all races, macular degeneration is very age specific. Then patients with advanced macular degeneration and the less advanced form of it, they're divided into two segments. Really, the people that are affected by macular degeneration in terms of day-to-day functionality are people with advanced macular degeneration, and that's a smaller portion, but you can still see significant portion of the American population. So let's go over what really macular degeneration is. To start, we'll just go briefly over how the eye works. So in this diagram, as you can see, light comes from the front of the eye. This is the cornea. It's the first layer that it hits, goes through the pupil, through the lens. The lens kind of sits in the middle. That's where people get cataract generally.
Doctor, I'm sorry to interrupt you.
Yes,
is
of course.
everybody seeing, in which slide are you right now?
I am on the slide that says anatomy of the eye.
Okay, so everybody's seeing the doctor changing slides?
No.
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 Okay. Okay, well then that's good to know. Thank you for checking there. So why is it that the screen is not being shared?
Okay, so can you pass? No, we are seeing your first slide. So
Right.
you need to pass the slide to the next one.
Well, I am, but I'm in the slideshow. Maybe the slideshow doesn't work in this format.
Yeah, we are not seeing the slideshow. We are seeing as the
Maybe
regular
now
class.
you see another.
Now it works. Yes, sir. Now
Okay.
it's working.
So this, we have to kind of go like this then. And does it show the entire screen? Because this way you're going to see my slides, not full, not take the entire screen up, if that's okay.
But we still see it big.
Yeah,
We still see it
at
big,
least
Doctor.
you see it.
Yeah. That's fine. It's working.
Yeah, okay, good. So thank you for checking again. We reviewed everything. I just want to show this slide real quick. This is the age and prevalence of macular degeneration. You can see as the age of the person goes up, the risk for macular degeneration increases significantly. And I'm going to go back to where the eye works. Thank you for letting me know again. I don't know if the pointer also shows or not. So can everyone see my pointer moving around on the screen?
Yes.
Great. So the light is coming this way. This is the cornea. You have the pupil that the light goes through. Then you have a lens that sits in the middle part of the eye. That's where people get cataract. And when you have cataract surgery, you essentially are replacing this lens with a plastic lens. Then everything else happens, and that's when the light gets focused onto the retina. So the light gets focused on the retina, and if you're looking face on, this is what the retina looks like. This is right here in the back of the eye. And the macula is the center part of the retina. That's all macula is. Macula is just a region in the retina. So the light gets focused on it, and the central 5 degrees of the macula is really what we see with in terms of seeing to be able to read and recognize faces. This really is what gives us the high acuity vision when they say someone is 20/20, 20/30, 20/40, is determined by how well this center part is seen. Everything else is seeing motions and trying to detect other things in the eye. But the central 5 degree is really what's giving us the central vision. And that's where macular degeneration affects. Again, if you look at the eye from outside in, this is what it looks like. And this is the macula right in the back of the eye. This is the en-face of an actual eye. You can see the nerve is right here. These are the blood vessels. And again, the macula is right here in the middle. If you look at a cross section, the retina has many layers. It's a very, very complex organ, even though it's such a small little organ. These are all the layers of the retina, and this is the macula right in the middle. This is a layer that the retina sits on. So the retina is sitting on this pigmented layer, and that pigmented layer does play a role in macular degeneration. So I wanted to point that out to you. And this is the back wall of the eye. There's, generally speaking, two types of macular degeneration. One type is called the dry macular degeneration. AMD is just age-related macular degeneration. So that's what this stands in my slides, age-related macular degeneration. So the dry form of the macular degeneration is the more common form of it. It's typically less severe, although there is an advanced form of it. That's the severe case, and it does cause vision loss. But most commonly, it's in a less advanced form, and it's not really affecting patients. And most people do not know that they have it if they're in the early or middle stage of macular degeneration. That's one of the dangers of macular degeneration. Then there's a wet form of macular degeneration, which is the more advanced form of it typically. It's less common, but more severe. So if left untreated, almost everybody will lose their central vision. And the reason it's called wet macular degeneration is because you get abnormal blood vessels that grow into the retina and bleed. They leak fluid and they bleed. So they just made it simple and said wet macular degeneration. The dry form of it has these yellow deposits under the retina, and we'll get into that a little bit more. These are called drusen. These are white little deposits. They're accumulation of cholesterol and proteins that build up. They're byproduct of just working retina. The retina is not able to process them and get rid of them properly, so they build up and they cause the macular degeneration. Now, the advanced dry macular degeneration causes atrophy. That's loss of tissue. So if you look at the color in the middle part of this retina, the color is very different than the other areas of the retina, and that's because this retina has gone away. It's atrophy. And that's the advanced dry macular degeneration, for which there's really no treatment, and it does affect people, and it does cause vision loss as well. Just looking at the macular degeneration again on the side and on the front, you can see if you look at it on the side, this is the pigmented layer that I was talking about, and that's the retina. You get these little yellow deposits under the pigmented layer in the retina, and then in the wet form of it, you get these abnormal vessels that grow into this pigmented layer and into the retina, and they bleed. So that's the wet macular degeneration. That's the dry. And the type that causes atrophy, these pigmented layer goes away, and the retina on top of it also atrophies and goes away, and that's why you lose vision. The wet macular degeneration, in the more severe form of it, if we don't treat it, it causes scar tissue formation. So you get this area that had previously had a hemorrhage. Again, I'll show this slide. You had a bleeding spot or leaking spot in the middle. And if you don't treat it, this scars down. When you have scar tissue in the middle of the retina, there's really not a lot that we can offer patients at this stage. Because this scar tissue cannot be removed, and that scar tissue has extended into the retina, and the photoreceptors, which are the seeing part of the retina, are affected. So what happens in terms of symptoms? Well, the first symptoms that most people notice are distortion. So the center part of the eye, if you look at a grid that has straight lines on it, you start seeing curvy lines, and those curve in and out, and they just cause things to be blurry. And if you're looking at people, you can see that their faces are going to be difficult to visualize. And that's another picture of the layers in the retina. And we're actually able to use diagnostic tests most of the time in retina practices, but even some optometry practices have some of these tests. One of the most important ones is called an OCT. And the OCT, the optical coherence tomography, basically gives us a live shot of the retina in cross section. So this on top is an anatomy slice of a retina, And this is an actual live retina that we're able to see and visualize in the clinic. So it gives us very good contrast. The other test that we use often is called the Fluorescent Angiogram, and that's an angiogram where a dye gets injected into the arm, and then pictures get taken of the back of the eye. If we put the two tests together, you can really diagnose macular degeneration very well. On the top picture, you see a picture of the retina. You have some bleeding areas on the edges. When you do the dye test or fluorescent angiogram, you have these areas that light up and they leak. Those are the leaky spots. And then if you look at it in cross section, like we were showing previously, you have these areas that are dark where there's fluid accumulation into the retina, inside the retina as well as under the retina. And that pigmented layer is really jumbled up and down. So that's what macular degeneration really looks like. What do we have to do to treat macular degeneration? So treatment options for dry macular degeneration, there's really no treatment option currently available. There are many clinical trials looking at emerging treatments for dry macular degeneration, and we'll go get into those a little bit later. Lifestyle modification is really the mainstay of therapy in this type of macular degeneration, just to delay the progression of the condition. And there are dietary supplements, which I'll briefly review as well. For the wet form of macular degeneration, really you need to get treated, and you need to get treated by a retina specialist in a timely manner to avoid vision loss. And we'll get onto those treatments as well. So understanding the risk factors, knowing what the lifestyle modification entails, proper examination and screening, and timely treatment are really the mainstays of what we need to do. So early macular degeneration, really you just have to do risk factor modification. You can see these little yellow deposits, those are the drusen. So this patient has early macular degeneration, and they need to just change their lifestyle, and we'll get into what helps. There are eye vitamins as well that people can take in the later stages of macular degeneration. They don't necessarily help the early stage macular degeneration. And the main reason is that in early stage macular degeneration, the risk of getting worse is very little. So risk of progression is 1% in the next 5 years. So it's very difficult to really get something that reduces it even further. So vitamin supplements are not necessarily recommended at that stage. For the intermediate and advanced form of the condition, though, eye vitamins do help. And there's a formula called the Age-Related Eye Disease Study formula. And these are over-the-counter vitamins. The AREDS vitamins have been shown to reduce the progression of macular degeneration. So they reduce the development of advanced macular degeneration, either advanced dry macular degeneration or wet macular degeneration, by 25% over 5 years. So these are things that you really need to be on and taking consistently over a 5-year period of time to have any kind of an effect. This is kind of a summary of what the vitamins are in the AREDS formula. There's 2 different formulations, both work, and they're not just normal daily vitamins. So this is a very specific formulation of vitamins that was studied at very high doses of antioxidants, 500 milligrams vitamin C, 400 international units of vitamin E, beta carotene, zinc, and copper. There's an addition of lutein and zeaxanthin, which are minerals that are found in the retina, and these also have been shown to work, especially for patients that cannot take beta carotene. Some patients smoke, and for patients that smoke, beta carotene is not recommended because it's associated with an increased risk of lung cancer. So we usually remove this and add lutein and zeaxanthin. In fact, the formulas these days that are out, most of them don't even have the beta carotene. They've been replaced with lutein and zeaxanthin. So really the risk factors of macular degeneration are age, race, with Caucasians being at higher risk, smoking, family history, which goes into the genetics, and gender. Women get it usually more than men. Cardiovascular risk factors are also important, but not as significant in terms of risks. Modification of risk is really the most important thing. If someone smokes, really my most important take-home message for them should be to stop smoking. Nothing that we do helps as much as the patient's not smoking. In fact, the risk factor modification is 2.5 times or 250%. So you can see the eye vitamins only reduce your risk by 25%, but not smoking changes it by 250%. Things that also help are exercise, proper eye protection, and eating healthy. So healthy lifestyle really makes a difference for your eyes as well. Things that are good for eating for macular degeneration are mainly dark leafy green vegetables. Fish has also been shown to help if it's consumed 2 times a week. And other things that have the good fats, such as nuts, are also useful. Again, stop smoking, manage your blood pressure, manage cholesterol and weight, and avoid saturated and processed food, saturated fats and processed foods. From a caregiver standpoint, I think it's important for caregivers to understand what happens with patients with macular degeneration when they lose vision. They lose the central vision. So face recognition is really one of the main things that goes away, and reading, being able to write checks. You know, generally speaking, patients can be functional. They can get around the house and they can, you know, eat and feed themselves, but they will not be able to drive. They're going to have a difficult time recognizing faces. There is a visual hallucination that some people get. They see flowers or shapes or people that are not there. And that happens really when the central vision is no longer there. So these are important things for caregivers to be aware of. The other thing that I usually recommend is just for people to be present when there is a loved one being examined, so that questions are answered. We went over what the interference with daily life is. There are different services and devices that can help with low vision. Things that people can do at home is getting better lighting, having more contrast while reading. The one thing I always recommend is if someone is able to use an iPad, to read, because they can increase the font and they have much better contrast. So that's something that people can consider. Now, using handheld magnifiers is useful, as well as stand magnifiers. These are sold at all the pharmacy stores. There are other reading assistant devices called CCTVs, where you can put a magazine under a reader and it will read it for you. Now and then we can get into surgical options as well. There are surgical options for patients with advanced disease. There's a telescope lens that was FDA approved a few years ago that can enlarge the images for the patients to be able to read. Generally speaking, it works for reading vision much better than distance vision, but it does help a subset of patients with advanced conditions that cannot be treated. Let's talk about treatment options for wet macular degeneration. There's been many treatments tried, because again, this is a more advanced form of it that causes issues with decreased vision, especially if not treated properly. Initially, we started with lasers, surgical interventions were tried, a modified version of laser was done, and then we got into the era of pharmacotherapy. So from 2004 onwards, we've been getting many different types of medications that come on the market and can be injected in patients' eyes to reduce the risk of vision loss. And they're very effective. The main thing about treating wet macular degeneration is really getting to see a retina specialist in a timely manner. That's the most important thing. Most of the time, these can be treated properly. And this class of medication is called anti-VEGF medications. The names and the different classification is less important. The main thing is to be able to get to the doctor to get these medications injected in the eye. Avastin is the most prevalent one used, as the less expensive one, and that's the most frequently used intravitreal medication around the world. Just going through what we have done previously as laser therapy is to laser these abnormal vessels off. Unfortunately, it does leave behind the scar tissue in the laser field. So that's not being used, and unless there's an exceptional circumstance, typically these are not used. This is how the anti-VEGF medications work, in that you have abnormal blood vessels that grow, and these medications come and stop the growth of these abnormal blood vessels specifically. This chart is really very revealing, very, very staggering outcome when it first came out in 2006. Lucentis was the first one that was approved, and you can see the separation between patients that were not treated. So initially, when this trial was done, there was no other treatment other than laser therapy. So the patients in the lower part of the chart in both of these trials got either nothing or they got laser therapy. And you can see everybody on average loses a significant number of letters of vision. This is 14-letter loss, and this is a 10-letter loss. However, if you got treated with anti-VEGF medications, on average, you gained vision. And in fact, 90%, more than 90% of people did not lose vision. So this is very significant breakthrough for our field of medicine in retina care. Now, this is what happens when you actually look at the anatomy of the eye. This is, again, macular degeneration on the side. If you look at the retina, you have fluid in the retina and under the retina, and after the treatment, all the fluid is gone and the vision improved. These are basically antibodies. I'm not going to get into the detail of what is currently available. We can get into a little bit more of that in terms of what's coming to the market, but these are basically monoclonal antibodies. They're antibodies to which block a protein that's secreted and causes these blood vessels to leak. These are the different iterations of the antibody that we have available, and they've been modified and synthesized. And the latest one available is ViewView, and that's a small molecule that works and reduces the leakage of blood vessels. Let's look at what's coming in clinical trials. So you can see that I didn't mention anything about advanced dry macular degeneration in terms of treatment because there's none available currently. However, there's a lot of promising clinical trials ongoing. So just a brief overview of what a clinical trial is. So there's many different stages in the clinical trial, and they're not all equal. So preclinical studies are done basically in animal models to prove the concept that a medication that you're trying to do or a device actually works. Once you have proof of the concept and you've tried safety trials in animals, then you move on to the different phases of clinical trials that go into the human eyes. So this is the phase 1 trials. These are safety trials, and they're done mostly on patients that have no other treatment options available. Then you have phase 2 and phase 3 trials. The phase 2 starts looking at effectiveness, and the phase 3 trial really are the big clinical trials that are done to look at both safety as well as efficacy in a very large number of patients to prove that this drug is both safe and effective. This data then from the phase 3 trial goes to the FDA for approval. Then you have public use. Now, when you have public use, that's still tracked. Even after something goes to market, there's tracking, post-marketing tracking, and sometimes in what's called the phase 4 trial to look at safety. So looking at what we currently have, this is the model of what happens in wet macular degeneration. The problem is that you have increased secretion of these molecules that cause leaky blood vessels, and we have different ways of attacking them. So far, we've been attacking them at the stage where you have antibodies blocking them. However, there's clinical trials trying to block the formation of vascular endothelial growth factor or VEGF from even being produced. So they're going at upstream factors that are affecting it and some transport proteins as well. This is another schematic of what happens with growth factors and VEGF in particular. And these are all different parts that we are attacking in terms of clinical trials to stop this wet macular degeneration or actually improve upon what we have. So the current therapies and their shortcomings are that they need very frequent dosing. So we need to continue to inject patients on a monthly basis in their eyes. And of course, there's a convenience factor as well as safety factor when you do repeated injections. The injections are generally very, very safe and well tolerated, but of course it would require a commitment to come in every 4 weeks. Now, the newer molecules that I showed actually in the earlier, the newer molecules on this side do last a little bit longer. There are medications that last 8 weeks and 9 weeks and 10 weeks, but really nothing that lasts more than 10 or 12 weeks. So still repeated injections are necessary. So one area of research is really trying to look at what delivery mechanism do we have to try to reduce the frequency of treatment. So in wet macular degeneration, another thing that we're trying to do is do gene therapy. So deliver a gene that can produce this antibody inside the eye itself. Instead of having to inject it repeatedly, can we deliver a gene and have the body itself start making these antibodies? So how do we do that? We stick this genetic material that we want to deliver to the eye between a viral vector, and that virus is able to insert itself in a cell. What a virus does best is insert itself in the cell and make the cell make its genetic material. So we're tricking that virus and using it to basically transfect the cells into the retina. So we inject a medication under the retina in surgery. It's a very delicate surgery, as you can imagine, a very, very thin layer. And you deliver that gene to these pigmented cells again. So this layer is going to start producing these cells. And then instead of having to do repeated injections, we just deliver this once and you have it work. That's a view of it in surgery. This is a bubble that you created. And this is a very, very fine needle. It's a 41 gauge needle that delivers this material under the retina. Any role for nanoparticles? So you may have heard of nanomedicine and nanoparticles. Certainly that's a very active area of research. And by the way, I've been involved in most of these different stages of research. But one of the main ones I've been working on is the nanoparticle delivery system. And basically, it's a delivery system for a medication that goes directly in the eye. There's different routes of delivery, but basically what it does, these nanoparticles directly target these blood vessels. Instead of the medication going everywhere, the nanoparticles are able to concentrate the medication directly to the blood vessels that are affected. This was our particle that we used, and we're still in clinical trials with this. And this is just a schematic of the reduction in size of these abnormal blood vessels. In the lab, you can see there's a larger initially, and after treatment, they start shrinking to a very small number. Let's talk about dry macular degeneration. What are we doing in dry macular degeneration? So again, just to review, what happens is that people lose the central part of the vision because of atrophy. There's no abnormal vessels in this. You just lose that central part and atrophies away. So what we're trying to target here is to basically stop the reduction or atrophy from getting larger and larger, because this continues to enlarge. When it gets to the middle is when you lose vision. So one of the main things that happens in macular degeneration is thought that there's complement factor overactivation. So this is a complex mechanism, which I'm not going to get into, but there's a branch of our immune system that works against bacteria or any pathogen that attacks us. And that branch is thought to be hyperactive in macular degeneration, specifically in the dry advanced macular degeneration where you have atrophy. So there's a compound called H.E.L.P in clinical trials, and this is the one that's going to be first to market probably. They're in phase 3 trials and they're extending the trials. We are currently participating in this clinical trial as well in my clinics. And this is targeting C3, which is part of the complement pathway, reducing its overactivity. And the thought is that by doing that, you reduce the progression rate of the macular degeneration. These are the charts of patients that were treated with nothing. You can see they've had large areas of atrophy, and then when you do treat them with this H.E.L.P compound, you can see that you're still having progression, but you're reducing the progression rate by about 30% in the first year. Again, these are preliminary data. We're still working on this larger trial to see what happens. Any role for stem cells? And there is a role for stem cells. This is another clinical trial that I participated in with collaboration with my colleagues at USC. And this, for this clinical trial, we used patients that had very advanced macular degeneration that already lost the central part. What can we do? Can we replace that? So this was a replacement trial. What we do is in this little monolayer, this is a synthetic layer that we grow stem cells on. So we were able to have stem cells that produce that pigmented layer and underneath the retina. And that's the layer that gets affected first. So we grow that pigmented layer using stem cells on these grafts. Then with surgery, we put this underneath the retina. It's a very delicate surgery again. So this is a patient with advanced macular degeneration. The central part is gone. We operate on the eye and then we place this little monolayer of pigmented cells under the retina. And then with testing, again, these are preliminary phase 1 results. This is in the process of getting approved for phase 2 now. You can see patients prior to having them placed have they're not able to pinpoint. These are charts that look at central 2 and 4 degrees of vision, and they're not correctly able to pinpoint exactly where things are being shown to them. It's a type of visual field. And when they do have the transplant, not all of them, but some of them are really much, much better able to pinpoint the accuracy of what's shown to them. So those are the treatments that are coming on. There's, again, a lot more research that's being done. I wanted to say thank you again for everyone that's joined us. Again, if I can be of any help, please feel free to reach out to me directly. My email is on this page. You can email me. That's my office location. I'm certainly happy to see anyone for any exam or anything else that they may have. I think it's time for discussion as well. So if anyone has any questions that we can answer, I can be of help. I'm open and ready to take any questions.
Doctor, I have a question.
Of course, ma'am.
I've been getting the Avastin in my eye for like over 3 years now.
Yeah.
It has reduced the progression. Doctor shows me on the chart.
Right.
But how long can you keep taking these?
Yeah, so that's a very good question. And that's a very common question as well. So patients that have been getting injections in their eyes have been getting them for many years. In fact, when we do follow-up studies on the patients that originally started in the clinical trials, after 7 years, still about half of the patients needed injection. So I have patients in my practice currently that I've been treating for about 10 years now. So certainly treating the patient and treating the eye over and over with injections has not shown to really harm the eye. The important thing is to not undertreat. So one of the things that happens commonly is that people don't get enough treatment and they lose vision because of progression. But if there is a treatment frequency that your doctor thinks is appropriate, that's what you need to continue to adhere to. Now, the treatment frequency for most patients is much less often than every month. Typically, patients are getting these injections on the long run, not initially. Initially, people get them more often. But after 1, 2, 3, 4 years, I would say, 70 or 80% of patients are able to go 7 or 8 weeks or beyond in terms of the frequency.
That's what I'm getting.
Yeah,
right.
yeah. So most people fall under the realm of not needing the injections monthly. It's usually every other month, maybe every 3rd month. And really, when you have that type of frequency and you're able to maintain the eye with low frequency, meaning less than every month injections, that's probably best. So 3 years, to answer your question again, is not very long, and it's totally appropriate. Now, every once in a while, I do reevaluate patients to see if they can go longer. So usually I go 1 week at a time. I reduce the frequency by 1 week, meaning extend the intervals by 1 week and reevaluate. The reason I do it that way is because when you go 1 week out, even if it starts being active, you still don't fall behind the ball. You're still able to catch up. But if you're able to extend it by 1 week, that's great. That's one less week that you have to come in. That's 1 or 2 less injections per year. So, continue to do the frequency that needs to be, and then every once in a while, try an extension and see if that works. I hope that answered your question.
It did. And the other thing is when one eye is worse than the other. So on the bad eye, periodically, I get this weeping in that eye.
Yes.
And sometimes they've treated it with an antibiotic.
Right.
But now it doesn't happen often, maybe once a year or whatever. Is that because some dirt or something gets in your eye?
Yes, that's typically because of either dry eyes or because there's oily glands in the eyelids that get blocked and they don't produce enough oil to cover the eye with oily tear and make it comfortable, and that produces dry surface of the eye and it makes the eye gooey. That's 100% true. And again, like you said, most of the time you don't need to do anything other than warm compresses on the eyelid. That I'm a very big advocate of. So just warming up a piece of, a towel in the microwave, or they have these face masks that they sell at pharmacies where they have little sand in them or beads in them, and you can put them in the microwave. It warms it up. You close your eyelids and you put that on your eyelids, and that really makes it a lot more comfortable. It also produces better quality tear. I usually recommend 10 minutes of heat once a day to maintain it, and when it starts bothering you, maybe twice a day, and that will really prevent anything from getting to a point of needing antibiotics. But periodically taking antibiotics or steroids is not really a harm to the eye either.
Thank you, doctor.
Of course.
Oh, doctor, I have a question.
Yes, ma'am.
Oh, how important, if at all, are wearing sunglasses outside to prevent this sort of thing?
Yeah, so I think sunglasses and generally UV protection is important throughout the life. So this is one of the things that I would really advocate for children to start at that age and have that habit all their life. Sun protection and UV protection is important for macular degeneration. It's also important for cataract progression. So we find that patients that wear sunglasses on a regular basis or have less sun exposure have the cataract formation is delayed. The other thing that's useful is transition glasses. Sometimes if you have transition glasses, that has UV protection built in it. So all you need is really UV protection. So that's a very, very good point. I'm really happy that you brought it up. Sun protection is important and critical for general eye health, and certainly does play a role in macular degeneration as well. You don't need to wear them when you're not outdoors, but even if you do have macular degeneration, even in cloudy days, I would recommend doing it because you're still getting those UV rays coming in. Now, the problem with that is that your contrast sensitivity sometimes goes down. So you really have to see, to be able to see to function properly, but obviously also protect the eye. The other thing I do recommend is screens that have the blue blocker on them, or protective screens. If someone is on the computer a lot, if you are on the iPad or on your phone, using a night mode. I have my phone, my night mode is on all the time, and basically just puts a yellow tint to the light that's coming off the screen, and that reduces damage. But that usually doesn't make as much of a difference as sun protection does. But for people that are, for example, computer scientists or architects, or if you're they're on their iPad all day, I think protecting against blue light is also important.
Now, when you say transition glasses, is that they're sensitive to the extent of light and they get darker and lighter depending on the lighting?
That's exactly correct, yes. So
Okay.
transition lenses are for people that wear glasses all the time. And that's something you can ask your optometry doctor for. Those glasses, they just become dark as you go outside. Some people don't like the look, and it does take a little bit longer to transition back in after you get inside. So that may be bothersome to some people. But generally, it's very convenient if you do need to wear glasses, because when you go outside, you don't need to put sunglasses on top of your glasses.
Thank you.
Of course.
Doctor, is there something I did or didn't do to cause this?
For macular degeneration, again, so risk factors, the biggest risk factor is genetics. In fact, at my clinic, we're doing a clinical trial on the genetics of macular degeneration. So we are getting samples from patients and sending them off for genetics, and that will show us the gene that's not working properly. That gene also, there is one gene that we're treating currently. That gene occurs in about 3% of patients, but the rest of the genes, if they're not being treated, they do stay in a database, and as treatments become available, those patients are notified. So genetics is one of the most important risk factors for this condition. The other things that, again, cause this, some of them is just not in our hands, right? Genetics and age. Those two things we can't really modify, but things that we can modify is UV protection, and then the eating a healthy diet. Other than that, nothing else that you can modify. I mean, if you have it, generally speaking, there's a genetic predisposition to get it. There's nothing that you did specifically to cause this condition.
Thank you.
Yes,
Doctor,
ma'am.
one other question.
Of course.
Is drusen usually progressive, or can you have it and it's a static condition?
No, it's progressive, but the progression rate could be very different. And the whole point of doing lifestyle modifications and taking vitamins and eating healthy and wearing sunglasses is to reduce the rate of progression of drusen to something that's worse. So if you look at it over a long enough period of time, drusen generally get larger, they coalesce, and then they cause either atrophy or loss of tissue, or they cause abnormal blood vessel growth. Now, that progression could take years and years, or it could take decades. Some people have drusen at an earlier stage in their life, and those drusen behave a little bit differently. And part of it is probably because the pigmented layer that I showed a few times is a little bit stronger, and that becomes weaker as we age. So the drusen don't progress as rapidly in younger age. But generally speaking, if you look over a long enough time frame, all drusen are progressive. But the point is to make that progression rate so slow that you can outlive it, basically, and not have it interfere with anything that you have.
Does it help to start any of these treatments, the higher intervention treatments, to slow that down, or it's just going to happen?
No, that's a really good question. So we don't have a treatment currently for drusen. We've tried many different things. There have been laser treatments tried, and different types of drops and medications tried, but nothing seems to so far reduce the changes in progression of drusen. Certainly, there is no recommendation in terms of injections in the eye, and there's no genetic therapy currently for it. But I assume as we learn more and more about the genetics of macular degeneration, at some point, there will be treatment at those stages where you're transfecting a gene that's not working properly or causing the formation of drusen at an earlier stage of this, so that you avoid getting to the later stages. And that's the way medicine is working. We're trying to get to preventative treatments more and more instead of treating what's actually disease.
Thank you.
Of course.
Can you hear me? Hello?
I can.
Oh, okay. Hi, I'm Linda.
Hi.
And my question is, I was told that I have intermediate stage dry AMD,
Yes.
And I also have cataracts that I've been told now are a 3++ on a scale of 1 to 4.
Sure.
And I was wondering about what is the risk of having cataract surgery with dry MD?
Great question.
And 'cause-
Cataract surgery generally does not affect macular degeneration. The one thing that does happen, obviously, is that you do get more light in the eye. Your
Yeah.
own lens has a in itself has UV protection built in. So when you do get cataract surgery, the lenses these days also have built-in UV protection. But I certainly recommend wearing really good sunglasses after getting cataract surgery, just to reduce the excess UV exposure or light exposure to the eye. But getting the cataract surgery should not really interfere with your macular degeneration. No clinical trials have shown that kind of a link. And in fact, you will have better contrast sensitivity because the light that's getting into your eye is getting dimmer over time with the cataract progression. So a 3+ cataract is generally causing some discoloration in terms of what you see. The colors have changed a little bit. Your vision still may be very, very good. And in fact, I would only recommend cataract surgery based on how functional you are. So if you're able to drive, if you're able to read, if you're able to do what you do on a day-to-day basis without much interference, then I wouldn't recommend cataract surgery unless there's some other condition in the eye that's indicating you should be doing your cataract sooner than later. Generally speaking, cataract is done based on patient symptoms. So if you're symptomatic from them, you get glare, your vision is getting blurry, you can't get your prescription to be correct.
well, I
it's time to do the
do have
cataract.
problems with glare with any night driving, definitely.
Exactly. That's one of the indications to do the surgery. But again, it's never an urgent or emergent issue with cataract surgery.
It's not an urgent thing to have.
No, again, very rarely is the surgeon, and your physician would certainly let you know if there's an urgent need to do cataract surgery. But
The reason why I ask is because I went through this with my mother, and she had dry AMD, which I probably inherited since you said the genetics is the biggest risk factor to getting it.
yeah,
And that was about 5 years ago. And in 5 years, I've gone from beginning stage dry AMD to intermediate.
right.
But my mother's dry AMD went from dry to wet about 2 weeks after her cataract surgery, and she basically lost her vision in
Right.
that eye that we had the surgery in, and
Right.
couldn't see the food on her plate.
Right.
And so I'm frightened of it, but I don't know what to
Understood.
do.
How long ago was that?
My mother's, let's see, it would have been maybe, she passed in 2015. And I'm trying to think when she might have had the surgery, maybe about 2012.
So not that long ago. So, one of the things that I see very commonly, unfortunately, is that the time lapse between cataract evaluation and cataract surgery is long. So when you go in for an evaluation for cataract surgery, they see you, then they send you for measurements of your eyes, then after you do the measurement, then you have to stay in line to get scheduled. And typically cataract surgeons are booked out and very busy, generally a few months away. And I have seen several times happen where the patient was not known to have wet macular degeneration at their visit with the doctor prior to the cataract surgery, but discovered to have wet macular degeneration after the cataract surgery. And they probably transitioned somewhere in between. It could have even happened before the cataract surgery, but again, because of the time lapse, no one caught it. And patients sometimes think, oh, this is just my cataract getting worse. That's why I really recommend monitoring the vision very closely with these charts that are called Amsler grids. Amsler grids are these charts that have lines on them.
Oh, yeah.
So these lines start becoming wavy early in the process of macular degeneration. These days, I would say more than 95% of patients, if we come on time, we're able to help you not lose your vision. So
I
those are
couldn't hear
really,
the
really
last
good.
thing you said.
If you come on time, meaning you notice symptoms and you get in right away to see a retina specialist, typically you will not lose vision. So the odds are very, very good for maintaining vision and not losing vision, even if you were to have symptoms. So if you have symptoms and you come in with wet macular degeneration, more than 95% of the time we can save your vision if you come in early enough. So it's possible, and again, it's hard to know, but that your mother's symptoms may have even started prior to having the surgery, and they just got really worse after the surgery. By the time they got to see a retina doctor, they were at an advanced stage and it could not be helped. So I don't think that should be a concern for you. And the cataract surgery itself, again, is not a risk factor, but the time lapse between the time of the exam and the time of cataract surgery, to me, is one of the issues here. And that patients convert from dry to wet between the two and think that this happened right after their cataract surgery.
I think my retina macula doctor said to see him like a month before my cataract surgery if I went ahead and scheduled something.
Sure. Yeah, absolutely. I don't think that's unreasonable. But again, the main thing is for you to monitor this yourself at home and then periodically go in to get your eyes checked with the OCT to make sure that
I do. And I do add
Yeah.
the angular grid every day.
Yeah, I think you're going to be all right. I really don't think you should be discouraged in terms of not getting your cataract surgery scheduled.
Is
If
it
it's
a
bothering
danger,
you
is
enough,
it a
you
danger to wait on cataract surgery with when you have?
No, not really. And again, I would say that for majority of patients, there is a subset of patients that do start developing higher pressures in their eyes, or they develop a cataract that's very thick that causes problems in their cornea after they have it done. But that's a really small minority. Majority of time, the technology these days is so good, we can do cataract surgery in very thick lenses without any problems at all.
I'm also borderline for glaucoma, which my mother also had. So I don't.
Yeah, yeah. So yeah, there's many different things going on, but I don't think, again, you should be worried about doing the cataract surgery. If they think that it's indicated and it bothers you, you should get that done. And in fact, after cataract surgery, there's a large percentage of patients that do have some reduction in pressures in their eye as well. So that may help your glaucoma.
Yeah, I'm not diagnosed with it, but I am borderline and
Right.
glaucoma suspect because of my mother
Sure.
in the genetics.
Right. So yeah, and overall, I think you shouldn't worry about it, and you can certainly get it scheduled when it's time.
Thank you.
You're welcome.
Any more questions from our participants? No? Well, Dr. Salehi-Had, we wanted to thank you so much for your time, and we wanted to thank all the participants today. We hope that it's been helpful to all of you.
Thank you guys for joining.
Oh, I do have, I guess, something.
Sure.
Is there a chance that I came on a couple minutes after I think Carrie got everybody on, but you had not arrived yet. Is there a chance we can get copies of your slides from?
Absolutely. Absolutely. Carrie has the copies, and if there is a way that you can find to share them, absolutely. I can't see a reason.
We will, Doctor, we will. Thank you so much. And
Of
then
course.
with your permission, we would like to upload the recording. So
Sure.
all our, yes, so more people can.
Of course, my pleasure.
Yeah.
This was fun. I'm happy to do more information sessions anytime about any topic eye related, even glaucoma and other things that are not in my specific field. I'm happy to speak about.
Doctor, are you taking new patients?
Of course, yes, of course, anytime.
And the doctor's information is all typed in the chat box if you can access it. Else, please feel free to contact me and I will give you all the specific information, doctor's address, phone number, and email. Thank you.
All the best, you guys. Take good care.
Thank you, doctor.
Absolutely, my pleasure. And my email is there too. Feel free to email me if you have more questions.
Thank you.
Take good care.
Thank you.
Okay, bye-bye, everyone. Bye-bye.
Bye-bye.
Thank you, Carrie, for organizing.
Bye.
Bye-bye.
Thank you, doctor, so much for bringing us all this knowledge and sharing it with all of us.
Of
Thank
course.
you.
Thank you. Bye-bye.
Bye.
Bye.
And I will be sending you the link to Dr. Paz for the ones that they were asking me, okay? For Alzheimer's disease, for the clinical trials. If anybody is interested, please contact me and I will send you the link and all the information for all those trials and the video too. So it is pretty interesting, and plus all the information that we have to get via uploading from today's class. Thank you so much to all of you.
Thank you, Carrie.
Contact you, Carrie.
Thank you. Same here. Same here. Nice to meet you all.
Bye-bye.
Bye.
Carrie, how do we contact you?
Just give me a call, please, whenever you are available. Thank you. And the final message. Remaining recording time is 2 minutes, 48 seconds.
Yeah.
Vaccine clinic update. We are now accepting registrations for ages 12 through 15 for the Pfizer vaccine. Good morning. You've reached the Office of Health. This is Artis. How may I help you?
Hi, Artis. This is Linda Bonini. Is
Carrie?
Carrie available?
Yeah, hang on a second.